Welcome. Thanks for having me. My name is Dr. Jessica Feldman, and I'm here to talk to you about expanding DBS access in the community and general neurology world. I'm a board-certified general neurologist with Penn Medicine. I've been in practice now for 20 years. I started adjusting deep brain stimulators in my practice in 2021, and I'm here to talk to you about the benefits of general neurologists feeling comfortable with adjusting deep brain stimulators and how it really provides a benefit to your patients, to your practice in general, and to our communities. We're going to talk about how the Boston Scientific Illumina 3D programming is expanding patient access and making it more user-friendly for general neurologists to feel comfortable with programming, and DBS therapy and how it's efficacious in Parkinson's and essential tremor. I'm going to talk about DBS therapy care gap and why expanding access is important and how you as a general neurologist can help with the expansion of access and feel comfortable with it. I'm going to talk about the Illumina 3D programming and how it makes it easier for you as a general neurologist to be able to program and to feel comfortable with programming. We're going to watch a video on the 3D programming, and I'll go over a little bit about how it works. We're going to talk about good patients to screen for DBS therapy and how it's changed my practice. This is a slide that talks about the DBS unit itself, and it is a three-part unit. You have the lead that gets implanted into the brain, and there are three areas that we implant depending on whether you're implanting for Parkinson's, for essential tremor, and what symptoms you're targeting primarily. Then there's a lead wire that comes out, feeds down through the scalp, through the neck, and attaches to the battery that's put in the chest. It's a very small incision for the most part that the surgeons do. The lead itself, you can see a picture there, is a very small unit that goes into the brain, and it has multiple contact points that allow you to change where you're stimulating. For the most part, it's a very small incision with a very minimal head shave for the patients. And then you have the battery that's put into the chest, but the battery isn't just a battery. That's actually your brain for the unit. That's what sends the signal through the lead wire up to the lead itself. Some facts about DBS: it is FDA approved. They are well reimbursed by Medicare and other insurances. Unlike other procedures that are used for essential tremor, Parkinson's, thalamotomies, this does not actually destroy any areas of the brain. It is reversible, it is adaptable, and if you absolutely had to, you can actually remove the entire system. The newer DBS models are all MRI conditional. It is a proven and durable therapy. So in studies, we've seen that patients who have DBS get 6 additional hours of on time, 51% improvement in the UPDRS scale. That is a huge improvement. And we saw sustained motor improvement for 5 years in the studies that were done. And I see this in my practice where oftentimes when patients first get their stimulator, they have to come in, they have to get an adjustment. But once we find that kind of sweet spot adjustment, I have patients who come in once a year. I have some who come in every other year, although I'd like to see them a little more often because they're doing so well. Compelling evidence to use a deep brain stimulator in essential tremor patients. 100% of patients who had a deep brain stimulator reported a perceived improvement in their symptoms in 1 year. They've reported that they've had 9 hours of tremor reduction post-DBS and then 12 months of clinical improvement in the quality of life rating scale. Patient satisfaction, there have been over 250,000 units implanted, so that's important to know that this is not a new procedure. This is not experimental. We have a lot of real-world evidence, and 96% of patients report that they have satisfaction, and the majority wish they had gotten DBS sooner, and I hear that over and over from my patients. Why is it important for general neurologists to start thinking about DBS as a part of their practice, not only referring, but also being comfortable with programming? The main reason that despite the proven benefits, despite the numbers that we saw previously, it's still a significantly underutilized procedure, and a lot of that has to do with access and comfort. There are a lot of patients out there who have movement disorders. 10 million people in the United States with essential tremor, another million with Parkinson's, but less than 1% of patients are referred for DBS. Being that frontline neurologist who takes care of these patients, feeling comfortable with DBS, feeling comfortable with adjusting it is a huge benefit for these patients and this unmet need. There is limited access to specialists. There's only 600 movement disorder specialists in the country and 9,000 general neurologists, which means we're the front line for these patients. Less than 9% of patients with movement disorders actually see a movement disorder specialist. So the majority are being cared for by their neurologists. A lot are still actually being cared for by primary care. And so this is a big part of why I wanted to get involved with talking to you and making sure that you feel comfortable, because this is such an unmet need. And I feel as though it is a disservice to our patients to not at least understand the therapy, understand how you can use it, why you'd use it, where you'd use it, and how you can be comfortable using it so that we can help the 91% of patients out there who don't have the luxury or ability to see the movement disorder specialists. The new Illumina 3D programming makes it a lot easier for you to feel comfortable programming DBS. It has an algorithm that helps generate patient-specific stimulation plans, and it also is easier to adjust, and it's much faster in the clinic for both the physician and for the patient, because we know that general neurologists do not have the same amount of time to spend with their patients than a movement disorder specialist in an academic setting may. I actually started programming DBS through Boston Scientific because of image-guided programming. It allowed me to see where the lead was, and then I could understand, okay, here's where the lead is, here's the structure that I'm stimulating, here are the structures that I need to avoid, and then I could see where the stimulation was in my patient. And it was a lot easier than the older units where you have the lead, but you don't exactly, you know which structure you're in, but you don't know exactly where the lead is implanted. And the lead isn't always going to be in the same place. And that has to do with the fact that not everybody's anatomy is the same. Not all surgeons are the same. So it's helpful for me to be able to see where that lead is, understand, okay, I'm going to need to adjust the stimulation based on where this lead is implanted, rather than having to do it blindly. This is a beautifully placed lead. This is actually, in my practice, what made me feel more comfortable. I could see where the surgeon had placed the lead. I could actually see where the stimulation was being provided, and that helped me to understand from an anatomical standpoint how the deep brain stimulator was working. Now, this is a really fancy program because the computer has all the nice mathematical calculation that we don't really have the ability to do easily. Basically, what the Illumina 3D does is it allows you to select the target anatomy, the structure that you want to mostly focus on, and then you can avoid regions that you need to avoid based on side effects or dyskinesia, other symptoms your patient may be having. And then the algorithm itself will come in and make this specific to the patient, and it's much easier than trying to go in and do this yourself. It basically gives an outline of the way that the stimulation should be set for the patient, and you can go in and just adjust accordingly from there. This is a slide that shows you the Illumina 3D programming in action. And this is an essential tremor patient. So essential tremor, we put the DBS lead into the VIM, and then the Illumina 3D slowly and gradually will go up to the stimulation settings. But the nice thing about the Illumina 3D is that when it provides the stimulation, when it does its setting, it's a really smooth sort of adjustment versus sometimes, in my experience, people feel much, much more comfortable and you can adjust faster, which is really nice. You can see in this video how quickly the tremor abates. Misconceptions about DBS. The biggest misconception about DBS, in my opinion, is that it's for end-stage patients. DBS is not for end-stage patients. DBS is for patients who are failing their current medication therapies for a variety of reasons, including tolerability, including limitations of which medications you can use for essential tremor, and we'll talk about that a little bit further on. But screening for the right patient population is actually what leads to success for DBS for general neurologists and allows us to feel more comfortable. The other big misconception about DBS is that only movement disorder specialists can do this. We don't have enough of them. And candidly, you're neurologists, you're smart, you went to medical school, you did a neurology residency, you understand neuroanatomy, and you're, no pun intended, cerebral. You want to learn, you want to continue to have that education. And so this is something that you can do. And a lot of the time it's just about that initial patient, getting the right patient, feeling comfortable, starting adjusting, and then utilizing the resources that Boston Scientific provides you. Patients have this misconception, oh, it's brain surgery. And it is brain surgery, but my neurosurgical colleagues might not like this, but it kind of is considered an easier brain surgery. It's a very small incision. It's not destructive. You're not removing part of the brain tissue. You're just implanting a lead, and then the wire is fed very superficially. It's generally a very quick procedure for the lead placement, and the recovery is generally quick as well. How can it help your patients? Without a doubt, DBS is the most effective with tremor, which is actually interesting because tremor is the most refractory symptom to medication therapy with Parkinson's patients. And so that's a nice kind of niche thing. It's also helpful for bradykinesia with Parkinson's patients with rigidity. It's really good for motor fluctuations. As we talked about, it helps with that off time. That continuous stimulation for patients is so nice instead of these peaks and valleys that you get with levodopa therapy. Aside from off time and on time, the levodopa therapy patients will tell you they feel this crash sensation. And also DBS will often help with that crash feeling in my patients. But there's something about that continuous stimulation that really helps with that off and on and those motor fluctuations. It can also be very useful for dyskinesia with your patients, depending on where you're stimulating. For essential tremor, 60 to 90% of patients report a reduction in their tremor, and a lot of essential tremor patients can get off of their medications. So when to consider DBS for your Parkinson's patients? This is where I think being a general neurologist, utilizing DBS is the most critical. The problem is, by the time the patients are getting down to see a movement disorder specialist, they're kind of out of that window where they're going to get the maximum benefit anyway because they're too advanced. DBS is not first-line therapy, but here's when I think about DBS. Number one, patients who are starting to require high doses of levodopa therapy. We know that over 600 milligrams of levodopa therapy a day increases the risk for dyskinesia significantly. So when I start to see that they're ramping up their levodopa dosages and getting closer or over that 600, that for me is a patient who I'm thinking about DBS. Anytime they're having significant side effects to the levodopa, but they're levodopa responsive. So you have patients who the levodopa therapy helps them a lot, but it causes a lot of orthostatic hypotension, or it makes them really nauseated, and so it limits your ability to use it. Those are great DBS candidates because you really want to be levodopa responsive before you get DBS. Those are the patients who are going to do the best with DBS. Also for patients who have a lot of off and on and those motor fluctuations, that smoothing of continuous stimulation, there's something about just continuously stimulating that movement center of your brain that really is good, I think, for long-term treatment in Parkinson's patients. Those are really good candidates for DBS. Who is not a good candidate for a DBS? Somebody with a lot of cognitive impairment, because it can certainly worsen that. Somebody who's advanced, and then patients who have contraindications for surgery. As a general neurologist, this is something that you should consider, in my opinion, as part of your treatment options in your patients with Parkinson's, because treating early has shown that these patients have slower progression of tremor and have long-term benefit. When are you going to think about it for essential tremor? Medication options are limited with essential tremor. We know that DBS is very effective for tremor. So anytime you're getting a lot of side effects from medications, you're having to ramp up the dosages of medications in order for the patients to have any control of their tremor, these are the people who you want to consider for DBS. Once I get a good program for these patients, they can kind of hold with the same program for a long time. I tend to refer a little bit earlier for essential tremor even. I practice about an hour to an hour and a half outside of Philadelphia, and sometimes 2 hours. And so being able to program DBS in my clinic has been revolutionary for a lot of my patients who didn't have the ability to go downtown every 3 to 6 months for programming, who weren't able to get into movement disorder specialists because there's a year wait to see them. it has really changed my practice dramatically because patients talk, they go to support groups, they go to rock steady boxing together for Parkinson's, and they say, I have a general neurologist who's comfortable doing DBS, who is programming a lot of DBS, and who you can see and you don't have to go downtown. So I've seen a significant change in referral patterns into see me. I've been able to set up a DBS clinic day in my practice, but image-guided programming and Illumina has really reduced the time it takes to program. And as neurologists, like I said before, we're all cerebral. We love learning. If we didn't love learning, I don't think we would do this. And so it really has brought a lot of joy to my career in terms of being able to grow from an educational standpoint.